Hello everyone, this is NSG3023 Final Exam Study Guide, Winter 2018. We'll start with the questions. Number one, you need to know the difference between diffusion, osmosis, filtration, and active transport. Diffusion is passive movement of electrolytes or other particles from an area of higher concentration to an area of lower concentration. Osmosis is movement of water across a semi-permeable membrane from a compartment of lower particle concentration to one that has a higher particle concentration. So, it's almost like it's the opposite. So, when you think of diffusion, think of it as being passive. Think of the fact that the water is trying to move towards an area that's of higher concentration to an area of lower concentration. Well, osmosis is the opposite. It's the movement of water through lower particle concentration to one that has a higher particle concentration. Filtration is the net effect of several forces that tend to move fluid across a membrane. Filtration is the net effect of several forces that tend to move fluid across the membrane. So it could be the result of it being particles. It could be the result of there being a higher concentration on one side, but it's the actual effect of what happens at the end, what's left over at the end. Active transport requires energy, so always know that active transport is the energy requiring movement of electrolytes or other substances across cell membranes against their concentration gradient. And that's from an area of low concentration to an area of higher concentration. So if it's from a low concentration area to an area of higher concentration, a lot of times you would probably confuse that with the osmosis. But all the difference between the active transport is the fact that active transport requires energy or certain electrolytes to move. Question number 2 is be able to describe and give rationale with examples of isotonic, hypertonic, and hypotonic fluids. In this, I will probably ask you, or I will probably say, well, this person is given 0.225 of normal saline, and simply just knowing whether or not it's isotonic, hypertonic, or it's hypotonic. If a fluid, for instance, has the same osmolality as your normal blood, it's called isotonic. And those type of fluids you would think of would be, of course, a fluid like a sodium chloride, normal saline. Also, fluids like lactated ringers and just plain B5 water are considered isotonic fluids. And as a result, those type of fluids expand. They'll like make the body's extracellular fluid expand. and causing water to shift in or out of the body. Hypertonic solutions would be like 3% saline, 5% saline, things with a higher concentration than just, isotonic solution. D10 in water, D5 in normal saline, D5 1/2 normal saline, D5 in lactated rangers. So, a lot of places say that there's no such thing. Well, a lot of places would like for you to know about like hypo. Hypo would be half normal saline because that's below a 0.9, which is half saline. So that would be an example of what one would call a hypotonic solution. Number 3 is be able to describe the mechanism behind thirst. The mechanism behind thirst would come, it's kind of like what one would call a conscious type of awareness or desire for a person to have water. Like if the fluid intake or the plasma osmolality increases, the blood volume decreases. So basically, the thirst control mechanism is in the hypothalamus of the brain. And we say that that's the center that controls everything. So osmoreceptors that are in that part in the brain, they tend to, like if the osmolality increases, then the hypothalamus stimulates thirst. So know that osmoreceptors are primarily responsible for a person feeling as if they are thirsty. Describe insensible water loss and effects on the particular organs. Okay, so the best way for me to explain this would be to say that if you have fluid output, it usually occurs through various organs, and there's primarily like 4 organs that are responsible for fluid output. These 4 organs consist of the skin, which everybody knows that the skin is a big organ, lungs, the GI tract, and the kidneys. Usually what one would call insensible water loss is not visible. And insensible water loss is a continuous process, and it usually occurs through the skin and lungs. So output of insensible water loss also increases, like if a person has a fever or something. So visible perspiration and that type of thing is not what one would call per se insensible, because you would see like sweat. You would see if a person is taking a lot of things through the GI tract and stuff. That's things you see. If a person's having diarrhea, they're losing fluid, but it's not something that you would necessarily see. if a person is urinating, it's not something that you would necessarily see. So if a person is not healthy, for instance, they can abnormally lose a lot of fluids, like through vomiting, or let's say they have wound drainage, or let's say they get in an accident and they have hemorrhage. They can definitely see that type of loss. But remember that water loss insensible usually increases with through probably more or less the skin or like the lungs. So know that that is what we're considered insensible water loss that may be exacerbated by somebody possibly having a fever or something like that. And that's the reason why, like afterwards, like when people, they'll get the chills or something like that, that's the reason why those type of things may happen. Be able to describe the mechanism in which fluid and electrolyte balance is maintained or regulated partially by hormones. Okay. The antidiuretic hormone acts on the kidney, and basically when it causes a person to hold on to fluid, antidiuretic, and so it causes the kidneys to like reabsorb water, reabsorb that type of thing. So if a person is having, let's say, a person comes in and they're having increased urine output, and the person, let's say they've been drinking alcohol or something. And a lot of times people, when they do have increased alcohol intake or whatever, they may tend to urinate. So what happens is, as a result of ethyl alcohol decreasing in your body, because of the fact it's almost like the fact that it is seeing that it's a certain, it's seeing that the alcohol is increasing, so therefore it's acting on the kidneys and stuff like that. And what it's doing is it's causing them to release antidiuretic hormone. And so when you have antidiuretic hormone stimulation, a patient will experience a decrease in urine output. So basically, if you have antidiuretic hormone released, a person will hold on to that. So the best way that I could say that a person, if a person says that you have release of antidiuretic hormone, that means that you're holding on to urine. If you have a suppression of antidiuretic hormone, that means that you're releasing urine. So know that that particular hormone that basically controls the output of your kidneys, and the function of your kidneys is the main reason that a person has whatever symptoms they have. So I want people to just remember that it's always the opposite. If you say anti-diuretic, that means that anti-diuretic means that you're holding on. You're reabsorbing water. And so as a result, you may be urinating the way you're supposed to be urinating, or you may, and that's okay. But so if you're if more anti-diuretic hormone is stimulated, a person could have a tumor, and it could be like overproduction as a result, or anything, well then that means that, wow, okay, we're retaining because we're not letting go of the urine. But let's say for whatever reason you taking a certain medicine, you drinking alcohol, you doing something that might suppress or stop the anti-diuretic hormone, then as a result, people might urinate a whole lot, So know that when something suppresses the anti-diuretic hormone or ADH, a person may urinate a lot, a person may continue, do things that quite, like it's the opposite. So that's what you need to know about that. Okay. The next question, be able to describe the mechanism in which fluid and electrolyte balance is maintained or regulated. Oh, I already said that because I talked about anti-diuretic hormone. Education, as far as education for clients that may be potentially at risk or something for hyperthermia, and hyperthermia means that you have an increase of, so we're on question number 7. Okay. Head injury. Oh, what I was going to tell you, I'm so sorry. Number 6, education for a client at risk for hypothermia. Basically, yeah. That's just, I put that out there, just a hypothalamus injury. I just wanted you guys to know that if somebody does have an injury to their hypothalamus, that could affect their temperature. But more closely, what you really, really, really want to look for somebody, if you want to look at urinary output, you want to look at that type of thing. But if you have somebody that is suffering from some type of complication, you probably don't want to so much as particularly concentrate on the temperature as much as you want to concentrate on the urinary output. And the reason why is because, remember earlier, I was telling y'all about I was telling you guys about the anti-diuretic hormone, and the antidiuretic hormone regulating body fluids and that type of thing. So that may be something that you want to take a look at. And remember, you guys, when we talk about stuff like when you're reading the question, and if it has something on the question, particularly like fluid or that type of thing, that's the type of thing that I want you to make sure that you pay attention to. That's the type of question I want you to know that's what they're asking you. So, make sure that you pay a particular attention to that, and know that the pituitary gland, which is the part of the hypothalamus in the posterior pituitary gland, releases antidiuretic hormone. So remember, we talked about hormonal regulation, and I want y'all to always keep in mind that when you talk about the antidiuretic hormone, know that even though the kidneys or the organ or whatever, the hypothalamus controls the release of the antidiuretic hormone, which is released in the posterior pituitary gland. And as we go like deeper, when y'all get into med surg, y'all learn about, y'all know what's being secreted in the anterior pituitary, what's being secreted in the posterior pituitary, and you'll know, oh, well, the growth hormone is secreted from this part of the, and that type of thing. So where is the thyroid stimulating hormone? Where is that secreted? So going forward. But we're going to start, and I want you to concentrate on the hypothalamus. And then the hypothalamus basically controls, because that's the message center, it controls the posterior pituitary gland. Out of the posterior pituitary gland is released antidiuretic hormone. And that's what I potentially want y'all to know. Be able to describe signs and symptoms of hyponatremia, hypokalemia, and hypochloremia. I want y'all to make, how we talk about, for instance, I'll start with hyponatremia. Hyponatremia means that the water enters the cells by osmosis, because it's trying to, like I was telling y'all earlier, with osmosis, movement of water is across semi-permeable from a compartment of lower to particular a higher particle concentration. So hyponatremia is mainly, you'll see people swell. Hyponatremia. And it would seem like it would be hyper, but it's the water that moves because it's trying to reach an isotonic phase. So it moves into the cells and it makes people swell. Hypokalemia is responsible for muscle weakness and severe cardiac problems like arrhythmias. Okay, hypokalemia. When y'all think about potassium, kalemia, I always want you guys to think about heart problems, okay? And if you think about heart problems, more than likely you'll get it right, okay? And that's the reason why, and it doesn't take much with potassium. And that's the reason why, for instance, when they have a person on diuretic and that person is spilling potassium, because they're urinating and they want you to replace that because they don't want it to affect your heart. They don't want your potassium level to go too low and you start having cardiac arrhythmias. And then the next thing that you need to look at is hypochloremia, is a low chloride level. And sometimes you'll see that with various type of acidosis. Most of the time, hypochloremia, believe it or not, a lot of people will not see a whole signs and symptoms when a person has a low chloride level. Usually it's a high chloride level that'll get a person going. It might have them with some type of renal function, and a lot of times it might work hand in hand with something. So I want y'all to just know that, and you'll have question 8 down. Question 9, what concerns would a healthcare provider anticipate with a patient on a ventilator related to acid-base imbalance? You got a person on a ventilator, and the person has acid-base imbalance. What type of things would you potentially look for, and why? Okay, so you got a person on a ventilator. You probably want to, first of all, you probably don't want the person to get acidotic, and you probably want, the first thing you want to do is always check the ABGs. And remember, I told you guys, arterial blood gases is the ABGs. And that's where we get mainly into respiratory and metabolic acidosis and alkalosis. So those are the type of things that you may want to look for. So you really want to, the first thing you want to do when you have a person on a ventilator, because a lot of times they're pumped, you don't want them to get alkalotic, and you're pumping so much or acidotic, depending on what the settings are on. You want to make sure that you're gonna look, and you're gonna make sure that that person's acid-base balance is what it should be. Let me see. Okay. Today I tried my best to just kind of go over a little bit about being able to distinguish between respiratory acidosis and alkalosis and metabolic and know the ranges. I wrote them up on the board, and I just really, to tell you the truth, I just want you guys to be familiar. And I want to tell you that a lot of people get caught. They get hung up on that. A lot of people, it takes them a while to process it. So I do want you guys to know what the normal ranges are. I do want you to know that the pH is 7.35 to 7.45. Acidic is less than 7.345, and alkalotic is greater than 7.45. So if you have a PaCO2 and it's increased, a person will be into acidosis, respiratory acidosis. If you have pH below 7.35, which basically when they talk about the pH, they talk about the hydrogen ion concentration being great, which makes the pH go low because you're talking about compensation. A person will be, if they have hydrogen, they have, I guess you could say bicarb level that is low, they in the blood, a person would probably produce respiratory acidosis. So it's like a lot of little different things that can happen in the cases. So but only thing I want you to do is I really, really, truly want you guys to be able to recognize those numbers, see what's high, see what's low, and be able to pick and choose without messing up what a person would be in. Like, for instance, let's say you got somebody that is, maybe they're vomiting, and so let's say, okay, we got another situation where you might have somebody vomiting. When a person vomits, they're losing acid, out of their body, right? And so with that being said, you should be able to know that that person, as a result of them losing acid out of their body, they're in a metabolic alkalotic state, for instance. So that's the type of thing we would look at. So basically, if it has some labs or whatever, make sure that you look at it like that. What is the best method to administer nutrition with somebody, for instance, that don't have any bowel sounds or anything like that. Of course, if you got somebody and they don't have any bowel sounds, you want to give a person the reason why we taught y'all about parenteral nutrition, which you want to administer the person parenteral nutrition. So that will be in the form of fusion of IB, so that would be the best way. If you have somebody that is, let me see. Oh, I did go over, I'm sorry, and I did talk, I forgot to say about, like time allotment and stuff. If you got a person with a low sodium diet and a person has like fluid restriction or something like that, what if I give you a bunch of times, what would be some of the best times to give that person fluid? And the best time that you would give a person the fluid, it would be during the regular hours of the day. You don't want to give people fluid at night and have them getting up. You want to give people fluid when they're active. I mean, it's like several, the person will receive 2 meals within that time, and most of the time that person takes most of their oral medications, and that type of thing. That doesn't mean that you don't give them anything at night at all, because you would measure it out and give them designated, but it will probably be less, because that is the point in time when you have a person like on fluid restriction. You got to make sure that you can count on the fact that they may take a little water with their pills or something like that. So you will give the majority of their medications and stuff primarily during the daytime, and as a result, you will give it then. Let me see. We got know when it's appropriate to administer an implanted port, peripheral IB, central line, peripheral inserted central catheter, which is a PICC line. Also, before I start on that, I just wanted to make sure, because sometimes when I'm writing this out, it's very hard for me to sometimes really be clear on how I convey it to you. But like, for instance, I want y'all to know that, like, if a doctor come up to you and tell you, oh, I need them to have a liter of fluid and some potassium, or I need you to put some magnesium, or I want you to put this. Well, basically what you do is you always inject that in directly in the line, especially if you're messing with something like potassium. I mean, you always inject it, directly in the bag. That's what I meant. Because especially if you're doing something like potassium, because potassium is so caustic that you really don't want it to burn the person or anything like that. So what you would want to do is you want to make sure that you put it in the bag and then you infuse it over time. There's a lot of medicine, especially if it's going in intravenously, there's a time allotment. Some medicines and some things, but rarely do they let you infuse, like electrolytes like potassium chloride and that type of thing. They usually will give that like an oral or either add it into the bag. Okay. Also, if you got a person, and I think I've said this to you guys before, about different things like, you got a person and they have CHF. I was telling y'all about that, where basically their heart is not working, they're not shifting the fluid around the way it should be, and you got that type of thing going on. What you really need to do is you need to make sure that you always put that person on daily weights. That is like a really big indication of someone going into like exacerbating, or getting really, really sick. And you always would do it on the same scale. You always would do it around the same time of day. So even like a pound up or whatever, that could alert you that that person could be in trouble. When I was talking about appropriate ports and that type of thing, okay, they have like implanted ports, and you can see these on your PowerPoint slides with notes and stuff up under it. But because I'm not gonna just read the whole thing out to you, I just wanna, when I do this, I wanna just put some thoughts into your head. Implanted ports, things like Mediports, and they're up under the skin. A lot of times those type of things are used because you have what you can call a person going to be on some type of long-term therapy. The same thing with a PICC line, a peripheral inserted central catheter. So if you're looking at implanted port, which they call a Mediport, and it's up under the skin, you're looking at a central line, or which like a triple lumen or peripherally inserted central catheter, which is a PICC line. They're all going to the superior vena cava. They all require sterile dressings, and they all are because people on chemotherapy, people are getting long-term antibiotics greater than a week or two. Know that if you put a peripheral IV catheter in, you have to change the IVs that we was talking about starting about every 72 hours. Because if you don't change it every 72 hours, eventually the vein will probably collapse, and you wouldn't be able to infuse anyway. And then you want to look at things like people having problems with it down the line. So you want to be careful when you have those. So peripheral catheters are mainly for short-term use. Okay, peripheral catheters. Okay. And then peripheral inserted central catheters or implanted ports and that type of things are for longer term use. Peripheral catheters, where we was doing with the number 20, number 18 catheter, and you insert and just starting a IV is, that's for long term. Okay. That's for short term. Like you might want to give somebody a liter of fluid, over 8 hours. Well, you would put a peripheral catheter in. You might have to give somebody some blood, and you just put a peripheral catheter in, and then you would make sure you give them their blood, and then after that, you might flush it and then remove it. So, as far as the next question, know how the steps to starting a peripheral intravenous catheter. You gotta first make sure, I just want to let you guys know that you first gotta make sure that you exclude any areas that, may be a problem site, and consider the ones that's birthed. For example, like if you got older person, you might want to look at them because they may tend to have fragile veins. And you may not want to start it on the dorsal surface of the hand because a person can bump or move the area. It's contraindicated to like start an IB if a person's site is red or tender or swollen. Avoid using an extremity if a person has a graft or a fistula, or if a person had breast surgery on that side. Also, you can also start a catheter on a kid in the foot sometimes, but you shouldn't start it on an adult in the foot because they say that it may lead to thrombophlebitis. So with that being said, I just wanted to let y'all, just tell y'all to know the steps, and I just want you to make sure that you know what type of things when to stay away from and what type of things to know about a patient. So that'll be like a couple questions to basically test you on that, and some of it you've learned in lab. You've learned about, you can draw blood from the antecubital, but you wouldn't want to start an IB in the antecubital. You know that you want to start peripherally and move your way up to the upper person's arm. You know that you probably would want to use a person's non-dominant arm, not their dominant arm, and the reason why is because you don't want to put it in the arm that's dominant, that they're moving around all the time, you know? So you need to know about that as well. Let me see. Okay, know the signs of phlebitis, infiltration, thrombophlebitis, and local inflammation. I'll explain this to some people in lab. So I'll start with, we'll start with phlebitis. Phlebitis is basically when you have inflammation of a vein. And I want you to be real clear on phlebitis. Think about the word itis. And signs and symptoms of phlebitis is redness, pain or tenderness, and warmth along the course of the vein, starting at the access site. And usually they say a red streak. You'll hear that a lot when people say phlebitis along the vein. And as a result, phlebitis can basically lead to what they call thrombophlebitis. Thrombophlebitis is the actual clot that can form, and it can dislodge in the vein and go up into the lungs, and a person can have an embolism and die, really. So phlebitis, which is that inflammation, can really truly be a problem if an embolus form. So look at that. A person that has infiltration is basically when the IB fluid is leaking to like the subcutaneous fluid. So for whatever reason, maybe somebody the catheter actually went through the vein, and instead of them getting fluid in the actual vein and into the circulatory system, the fluid is going around the surrounding tissue. So as a result, the symptoms, as far as the swelling, may be a little bit the same. There might be some slight swelling, but it's a lot more than if a person had a phlebitis. Usually when a person has a phlebitis, they have basically no to minimal swelling. It's just mainly soreness. And a lot of times, phlebitis, the inflammation comes because they're running fluids and stuff through it. Like they might be running gentamicin through it, or Banco, or something that's causing, those antibiotics be real, caustic, real powerful. And that's why it's very important when you have a peripheral IV site to change the site so often. But when you have infiltration, the catheter tip is no longer in the bag. So then you'll get swelling, you'll get paleness, you'll get coolness because the fluid is in there, and from decreased circulation around the venous puncture site. And also the IV might slow up and or stop. So you want to look at that. A local kind of inflammation is basically when the insertion site might be red or edematous and stuff. And that a lot of times might come from people not using correct technique, or somebody get ready to catch an infection because, they, didn't have it covered appropriate, or they're not really doing what they're supposed to do to take care of it. And then some people just tend to have their skin is very susceptible to problems. You might find them they might have a little allergic reaction and be scratching or something to the tape and catch a little infection or something. So you have to be very careful about that. So I just want y'all to know the differences between phlebitis infiltration, thrombophlebitis, phlebitis inflammation, red streak, think about that. Infiltration, cool, swelling, because it's not in the bag. Thrombophlebitis is the actual clot that would form, and then the local inflammation is, okay, hold up, sorry. Okay, so as long as you know those symptoms, you should be fine as far as answering a question. Know the procedure when experiencing a blood transfusion reaction. We all know what that is, right? If you start seeing somebody having a reaction to blood transfusion, because like a blood transfusion is a different type of site. And when y'all get to med surg, y'all are really gonna go into this stuff in depth. You need to always. Okay, I'm sorry guys. A lot of y'all been calling tonight. I'm so happy to hear from you. But anyway, let's start with, so I explained about, I didn't finish saying about the blood transfusion reaction. And if you was to see somebody, make sure you have to do stop the infusion first. That's the first thing that you would do. You would have to do whole new tubing. The compatible thing that you would run blood with is always okay, I'm sorry, I'm looking at another text from you. Okay. And you would infuse it with normal saline. When you do blood transfusions, they use a special kind of tubing called a wide tubing. One to have the spike for the blood, the other one to have the spike for the saline. So what you can do is leave the cap on which one it was that required that you would have had the blood on, and just you leave the spike cap so it'll stay sterile, and just infuse normal saline if you just wanted to keep the line open, because chances are if someone had a reaction, you probably would want to keep it open, because you may have to give them something, you may have to give them something IV pushed, depending on what they're going through. So if it's a accessible, wonderful vein, you want to make sure that you keep that open. The difference between reactive hyperemia, blanchable, so we're going into skin stuff now. Blanchable hyperemia, non-blanchable, and tissue ischemia is, I'm going to just say it, non-blanchable hyperemia is if you blanch, mean you touching it, that's that it persists after you palpate it. It stays red even after you palpate it. So, and a lot of times they say that indicates tissue damage. So when you press a finger against that red area, it does not turn light in color. Usually they say that's indicative of like some type of deep tissue damage, and it's present, and it's commonly the first stage of a pressure ulcer development. Reactive hyperemia is a redness of the skin resulting from dilation of superficial capillaries. It blanches most of the time. And in blanchable hyperemia, the area that appears red and warm will blanch, turn lighter in color, and follow the fingertip palpation. Tissue ischemia is decreased blood flow to the tissue, and it usually results in tissue death and occurs when capillary blood flow is obstructed. And that's most in the case of like pressure in that area. Okay. No difference between friction and shear on the skin. Okay, be able to know this, you guys. Friction is the force exerted against the skin, where basically the skin, it remains stationary and the bony structures move. So that is, shear is the actual force that's exerted against the skin. For example, like if you, if the head of the bed is elevated, the gravity causes the bone to pull toward the foot of the bed, while the skin remains against the sheets. So that's shear. Friction is surface damage caused by the skin rubbing against another surface, and that usually results in an abrasion. Friction will result if the patient is dragged across the sheets. Okay, you see what I'm saying? So you're actually getting some type of damage to that area. Let me see. Tunneling is, I didn't tell y'all about that. Sometimes when a person has like continuous pressure over an area, the deep tissue destruction, it just continues on, and often results in large pockets of necrotic tissue or dead tissue beneath the opening of the main wound that resembles a tunnel-like. and this is referred to as tunneling. Sorry. It's not usually visible to the eye, and a lot of times you can take like a cotton tip applicator and go down and around and through. I've seen some tunneling where people have even took their fingers and went in and stuff. And of course we know that moisture comes from a lot of stuff. It could come from wound drainage, somebody sweating or perspiring a lot, and or someone having urinary incontinence. And the thing about moisture is that it basically increases the risk for ulcer formation. Okay, so you know. We already know. Let me see. There are a lot of risks. I'm sorry. Question number 19. There are a lot of risks. The risk factors that can put a client at risk: pressure ulcer, could be poor nutrition, especially if a person has like a protein. To see, that's like a main one. It causes basically the tissue to become susceptible to breakdown. A person with excessive skin moisture, we said a person with decreased mobility, decreased sensory, decreased activity. All of these things are people at more risk for pressure ulcer development. So we know what we have to do as nurses. We have to position, turn, and that type of thing, and try to keep the patient clean. When you do a wound assessment, I'm going to take 2021 and 22 kind of all together as far as the wound assessment. So you know that you do staging, and you have staging from 1 through 4. So you have what they call stage 1 is intact skin, but it's non-blanchable in one localized area. It may be over elbow or knee, some type of bony prominence. Stage 2 is partial thickness, where they lose the dermis. And it might be a red, pinkish wound bed, and it don't have no slough or necrosis or nothing like that. And it's also, it may also be intact, or it might be open, ruptured. It might be a blister, a serum field blister. Okay, so that's a stage 2. Stage 3 is full thickness tissue loss. Subcutaneous fat may be visible, and that type of thing. But no bone, tendon, or muscle is exposed. So then you go all the way to 4, and that's when you get into the staging of the bone, tendon, you know, that type of thing being exposed. So be able to recognize the difference between those various stages. Okay. Then you have what they call stage one. So what I'm gonna do is I'm gonna make sure that you guys have like maybe like a couple stages that you identify. So I would say maybe 2 or 3 questions or 3 or 4 questions might be about staging. And I want you to be able to identify that type of thing. Also, what is the time frame for administering or tetanus injection? No, that's within 10 years. No, period. The time span, and I know that most of y'all should know that if a person has some type of injury or opening or something like that happening to them, know that it's within a few days. It's within 10 years when they're supposed to have. I'm trying to do a lot of things at once. I'm sorry. People, now they never call me until I'm in the midst of trying to do something, you know. Okay. So know that, maceration, dehiscence, evisceration, and debridement. You guys want to know that. You want to be like real clear on what that is. I could start off with telling you that, let me see. We could say maceration is kind of like when the skin is beginning to start to kind of break down. And what you're doing is, as a result, like when you, like for instance, when you cleaning somebody up and you're getting rid of urine and all of that type of thing, you are in the process of trying to prevent, breakdown or maceration. Dehiscence is when like a wound comes apart. Like let's say, you went and had surgery and somebody sewed you up, okay? Or stapled the area shut, and then the edges started to break apart. That's what they call dehiscence. Then next is evisceration. Evisceration is actually really bad. That's actually when organs protrude. Okay, so keep in mind evisceration, organs protruding. And then debridement is when you're actually removing eschar and black necrotic tissue to expose granulated red pink tissue. That's like a surgery. Okay. Know the use of wound care products, i.e. dry gauze, transparent film, hydrogel, hydrocolloid. Okay. So basically, let me see. You know what dry gauze is. You know what transparent film is. You probably would like to know what like gauze is just put on wounds. They got a little drainage just to keep them from leaking out. But hydrogel, for instance, is a transparent film. Is like what you put over on top of like an IV, where you can see, what's going on, and no tissue loss, you just putting it on there as protection, more or less. Hydrogel is when a wound requires a percentage of water or moisture. So, like for instance, you might have some good tissue that's healing good, that's pink, and you don't want it to dry out and crack or something. You might put hydrogel on it. And then you got hydrocolloid, which basically is almost like you want it to kind of grow into the tissue, and it's used for stage 1, 2, and 3, where there's a copious block of drainage, and just it requires a lot. So keep in mind the uses. When we talk about how to change a large buttock wound, when I say the stages, I'm just telling you guys, you need to consider giving the patient the analgesic. We talked about that. You're going to assess the appearance of the wound. You're going to assess the character of the wound. That includes things like the amount, color, odor, consistency. Then you're going to assess if there's any drains, where they're located. If it has a bag attached, you're going to allow it to drain and get I&Os. And then you're going to, if it's a surgical wound, you're going to make sure you inspect if it's staple sutures or wound closures. You got note for any irritation. You got note for anything that could show or display that there's a sign of infection. So when you first go, before you do anything, you want to make sure that you always inspect your wound prior, because if you don't inspect the wound, you don't know what type of treatment to do for the wound. Okay, so when you take care of things, and you know how a lot of times we just tend to do what we do, and I don't even know if we realize upon doing certain things why we're doing it, like the way that we're doing it and stuff. So what I want you to know is excuse me, I want you to know like why a person puts on a warm soak, why they put on warm moist compresses, sitz baths, cold moist compresses, deep heat. Why would a person do that type of therapy? So I'm gonna tell you, let me see, we can start, like I can tell you about a warm moist compact, okay, or warm soap. Okay, another purpose of therapies: warm soaps, warm moist compresses, sitz baths, and cold moist compresses, and dry heat. Okay, a warm moist compress improves circulation. It also relieves edema, and it promotes concentration of pus and drainage. Warm soaps involve the immersion of a body part in warm solution, and basically It promotes circulation, it lessens edema, increases muscle relaxation, and allows application of medicated solution of some sort. Usually that's kind of stuff they use for people who use maybe even had a surgery, a rectal surgery, or somebody after childbirth that had an episiotomy or painful hemorrhoids or that type of thing. They'll benefit from a sitz bath or a bath in which only like basically where the pelvic area is immersed in warm fluid. Cold moist compresses are used to relieve inflammation and basically swelling. And as far as just dry heat therapy, usually it's improves circulation, and it also relieves promotes muscle relaxation as well. And you just got to be careful with that because you don't want to keep anything warm on their body, overly long. So usually they'll say use it for 10 minutes or 15 minutes, then take it off, like that. Okay, know the various stages of wound healing. Okay, there's the proliferative phase, in which a wound healing is by primary intention, and basically it causes a new capillary network to form that provides oxygen and nutrients for new tissue and contributes to the synthesis of collagen, which is kind of like a fatty, elastic tissue in your body. In the inflammation phase, the goal is to establish a clean wound bed and obtain bacterial balance. If, let's say, there's exudate or pus or whatever you want to call it, a scab will usually form. When the wound involves loss of tissue, these heal by second intention. And basically the hemostasis phase is the stage that really just controls bleeding. So basically that's what all I pretty much want you to know about that. When we talk about the proper way to wrap an elastic bandage, I just want you to know that you would start at the periphery and move your way up when you if it's the arm, if it's the feet, you would start at the periphery and you would move the way up. Basically the biggest post-op concern for a client is making sure that the client can ventilate, can breathe after surgery. So you want to make sure that a person can breathe. So that's going to be why you tell them to cough, turn, deep breathe, that kind of thing, because you don't want them also to you don't want the person to catch pneumonia. And so, a client with abdominal binder post-surgery, I don't say anything about that. Make sure that they can just make sure when they have on the abdominal binder that it's just not impeding you getting to like neurologically, lymphatically, or none of the responses like their urinary tract or nothing like that is impeded by that. I did not mention about serious sanguinous and purulent. Serious drainage is what you pretty much want to see. It's pale, watery, and it's just a plasma, no odor. Serious sanguinous is pale, more watery, and it's a combination of plasma and red cells, and it may be blood streaked, and people used to say it come off as pinkish in color. Sanguinous is bloody, so I always think about it like that. Sanguinous is fresh blood. So you got the serious, which is clear, watery, plasma-like. Serious sanguinous might have a little blood streak in there, but it's mostly pale and watery. You got the purulent drainage. I didn't tell you, purulent is thick, yellow, green, or brown, and it's indicating the presence of dead or living organisms in white blood cells. So a lot of times when you see purulent drainage, when you say white blood cells, you know it's infection there. So it could be the green, it usually has odor, it could be brown, it could be, yellow, real thick, yellow green, and it could have some living or dead organisms in it. I told you about the elastic bandage. I did tell you guys that I wanted y'all to make sure that you store approximately ventilation. As far as the person, what is that? Know the profile of a client who is prone to suffer from pulmonary embolism. Is usually someone who has a lot of problems, and that person may be overweight, that person may be immobile, that person may be in taking various type of medication that might if they're obese, they might have decreased ventilation capacity. So those are the type of people that ideally you're looking at. People who smoke, they say a lot, and that type of thing. Those are the things that you're looking at. And I don't know, did I discuss unstageable? When I was talking about the wounds, I think I did not talk about the fact that when you have a wound and it's full thickness and it's tissue loss and you don't know how actually deep the wound is, that's an unstageable wound. Yeah. Let me see. Okay. So let's say the person had chemotherapy, and they and the best time would definitely be when the person's at a phase where they've been out of therapy for a few weeks, and they, more able to teach them, they're more able to listen, and their body's trying to, rehabilitate itself. So, yeah. What kind of person is at most risk for hypovolemic shock? Look at anybody that basically has had a major surgery with a lot of loss of blood. Those are the people that are most, at risk for hypovolemic, a lot of blood loss. Rationale for monitoring a client's blood sugar. If a person may not be a diabetic, sometimes they put people on steroids. Sometimes they say that the fact that there's a relationship between wound and tissue healing and hyperglycemia or blood sugar levels going up. So this is the reason why you would monitor for that. Early and late stages of malignant hypothermia. That's a post-op condition. Malignant hypothermia is really, to tell you the truth, supposed to be kind of life-threatening. So let me tell y'all the early stages or signs of malignant hypothermia includes high level CO2, tachypnea, and tachycardia, because everything is working. So think about that as the early sign. And as far as late signs of malignant hypothermia is elevated temperature. That's the only sign is elevated temperature. It's in the late stages. Okay. Let me see. When should preoperative teaching begin for a newly diagnosed? We already said upon if a person is diagnosed and they're not necessarily in the hospital yet, you may want to start a week or so before they're admitted. So let's say because a lot of times if you give somebody some information, and especially if it's not the best information or the best outcome that they thought about something, you have to give a person a chance to process things. And if a person, so maybe if they have time, it's more useful, they say, about a week or so before admission, and then you reinforce immediately before surgery, because a lot of times if a person is less anxious, then the teaching is more effective. And if a person is anxious and they have fear, that's basically like a barrier. They're not going to listen. Okay. Let me see. As far as clarifying different things, you know that they need to clarify information prior to a person undergoing surgery. They need to make sure that they are, alert, they understand what's going on. You need to give them time and stuff like that to discuss things and everything. So, as far as before they sign that consent, you need to make sure that everything is clarified and they have a clear understanding to their ability about what's going to happen. Prior to surgery, general anesthesia, fast again. Okay, so like let's say a person is going up under general anesthesia. When a person goes up under general anesthesia, y'all all know that they need to fast a minimum of 8 hours prior to surgery. If they are going under general, if it's some other type of anesthesia like a regional or sedation or something like that, they'll tell you to just fast for a couple hours or so. And then clear liquids, maybe like within 6 hours. But generally, if it's general anesthesia, it's within 8 hours, and they stick to that because they don't want people to aspirate. Okay, let's see. Why do people generally would tell them why do post-op time perform leg exercises? We know that's to prevent them having deep vein thrombosis, because you want to keep that circulation going and you want adequate venous return. Why does ruptured aortic abdominal aneurysm major surgery entail? A major surgery like that would probably involve extensive reconstruction or alteration in body part, and that poses like a real great risk to the patient's well-being. So there's a difference between a major surgery, which that would be considered. They have what they call urgent surgery, which is necessary for a person, and you're trying to prevent, something from happening. And then you have elective, where you choose to go under the knife. They have what they call diagnostic surgical, where they perform a surgery trying to find something. A lot of times you'll hear people say exploration or exploratory lap or something like that. That type of thing. So those are like type of things. Why do clients often shiver after surgery? A lot of times it's cool in there in the operating room, but the fact that the person they've been up under anesthesia, therefore their body function is kind of depressed. They're not, you know what I'm saying? It's going to cool down. So with them having a lowering of the metabolism, they're going to have a fall in the body temperature, and the operating room environment is cool. So just because they shiver, that don't mean that they necessarily have hypothermia, but it just means that their body functions as a result of them being up under anesthesia of some sort uh, and them having a lower metabolism makes their body temperature fall. So, and also shivering can be a side effect. There's certain anesthetic agents, I don't know if you learned about it in the form, where that can even be a side effect. Okay. Let me see. We talked about coughing being important because we gotta have them people coughing and deep breathing. What does physical preoperative preparation entail? Basically, did I? Oh, I must have missed one thing. I'm sorry, you guys. It's just getting late. Okay. Let me tell you the difference between the types of anesthesia. You got the general, that's number 44. You got the general anesthesia. It's gone, you give that doing major procedures that requires extensive tissue manipulation. Okay. Local anesthesia involves loss of sensation in one desired site. It's usually used during minor procedures like ambulatory surgery, usually where the recovery is between 1 to 2 hours. Regional anesthesia is when one area of your body, like when they give you a peripheral, like a nerve block, they give some women when epidural, that's a regional. And let's see. And intravenous moderate sedation, or they call it conscious sedation, is used during stuff like, I'm gonna get a colonoscopy. You kind of under, but you kind of not under, like that type of thing. Or if they give certain types of laparoscopies where they go in with a scope and they look at you, So it just requires a decreased level of sedation. A decreased level of consciousness, but not like a full sedation. Let me see. Prior to physical preparation, prior to surgery, you are supposed to have jewelry and all that kind of stuff safeguarded. Let me see. No makeup, no nail polish. You're gonna have post ops. They would have been NPO. Sometimes they may give you some type of prep. If they have hearing aids or anything like that, or any loose dentures or anything, all of that stuff needs to be removed. Okay. Let me see. I'm trying to see where I am. Be able to use and explain the overall function of the incentive spirometer. You guys know that it just basically expands the lungs, and you blow into it. It facilitates deep breathing, encourages force because you hold it and then you let it go. It encourages forced inspiration, that type of thing like that. Um, let me see. Next. Oh, we already said things about inaccurate O2 stats. You know that if a person is anemic, poor circulation, like got nail polish on, something like that going on, that's gonna show. Um, okay. When you write an outcome statement, because it's gonna be I want you to be able to write an outcome statement, and only thing I can say to you about that is the expected outcome need to be measurable, and it needs to be reliable, valid. It needs to focus right on the patient, and it needs, you need to be able to evaluate it. And the reason why is because if you don't meet your outcome, you might need to lessen or change. It may not be totally realistic for that person. So it needs to be patient-centered. It needs to be singular. You need to just be dealing with that one particular thing. You need to be able to observe it. It needs to be measurable, time limited, and it needs to be realistic. So you can't measure whether or not a person is happy. So you can't put that in there. You can't say that the person will be happy, and you know what I'm saying, because it has to be something that you can really observe. You can't really, you can assume if a person smiles, they're happy, but not necessarily. So it has to be something that, you can really look at. So if a person doesn't meet, like whatever the nurse's goals or her expectations or outcomes, then the nurse needs to change it. Okay. I think that y'all know what type of leadership skills that a street nurse, because y'all do it all the time when you're taking care of patients and that type of things. I would think that y'all would be able to pick out what type of leadership skills. I mean, you're going to be able to set priorities. You're going to be able to time manage. You're going to be able to communicate. And you're going to be able to tell people what to do, to delegate. So those are the type of things when we talk about in terms of what type of leadership skills. Basically, when you talk about family people and staff, that is just basically with them, what do you call it, collaboration among the staff, among, that's what they call it, interprofessional collaboration. It's when the family and the patient and everybody works together. when I asked y'all about comprehensive assessment approaches, that was like a while back. Oh God. And mainly, comprehensive assessment approaches would be, back when we first started, I just kind of threw this one in here, but there was basically two different comprehensive assessment approaches. Remember when we talked about Gordon's? This was like way at the beginning. Gordon's functional health patterns. And that's when you got that little, like, it's kind of like a structured database format. And then the other one is the problem-focused approach. And that's when you just look at, the patient's situation, and then you begin with the areas that are problems, So just think about that. There are two comprehensive assessments, the Gordon's functional health and the problem-focused approach. And as far as being able to prioritize using Gordon's, we already discussed that, and I go over that a lot. Remember, I always tell you guys to make sure, not Gordon, Maslow's, always make sure that you look at the physical first and the ABCs. So you're gonna be able to prioritize based on the things, to me, that are most detrimental. So if I give you a line of patients, I want you to be able to pick out, I'm gonna take care of this one first. Always remember airway. Always remember things that's affecting breathing. Always remember physical. Always remember that type of thing. Those are the most important, because you can't take care of anything else if you don't have a person's physical right? And you might have more than one physical. Then you're going to have to use your ABCs, right? Airway, breathing, circulation, ABCs. So first, you got to look and say, okay, let me see how I'm going to take care of the physical. That's using Maslow, because that's going to be the first thing. After you get that, let's say you got two things that are physical. Then you go into your ABCs based on that. Okay. Y'all know about, I told y'all about afebrile and that type of thing. So afebrile is not having a temperature, afebrile. And then febrile, without the A, febrile is having a temperature. And then sometimes you'll even see them write that a person is febrile, but they might say they don't, let's say they don't know where the fever's coming from. Sometimes you'll look on a chart and you'll see the FUO. And so if ever y'all look on the chart and you see FUO, that's basically fever of unknown origin. And that's an acceptable, thing to look at. Also, the difference between the systolic and diastolic pressure, that's a gimme. That's the pulse pressure. Abnormal heart rates, blood pressure, rhythms, names, and meanings. Basically, I'm just saying, if a person say that somebody is tachycardic, you know that they got fast pulse rate, right? You know this. So that's the type of things that I'm trying to look at or tap it with. What is that? You know, do you know what that is? That's the type of thing I want to make sure, like leaving out of here, that you guys know what that is. Okay? So just look at all your little things. If a person has a heart rate that is out of rate, and they need a pacemaker, it's probably because they had an arrhythmia. You know, be able to, and I'm not going into nothing very, very big, but I just want y'all to know what the difference is. What about things like orthostatic hypotension? How do you, I had that next. Okay. How do you know what that is? What would you tell a person to do? We already talked about it. Person needs to sit on the side of their raise, slowly sit and dangle before they start walking. They don't just jump up. That's where you get the people that basically a fall. The next thing that I need to get information I need to give you is about a hemiplegic patient. The best way to ambulate a hemiplegic person is what? First of all, you got to know what hemiplegia is. Hemiplegia means that the person generally has, they're like paralyzed, like on one side. So, you need to know how, as a nurse, you would like ambulate with that person. What type of things would you do? Would you be more prone to be on that person's weak side or on their dominant side? See, that's the thing. And believe it or not, you're probably prone to slowly walk in front of the person and be more on their dominant side. So just read up on that a little bit. But I think I kind of gave you a little information. Okay. Know about home safety, all stuff like well-lighted rooms. You don't want to have. This is really applicable to people if they ever think they might want to go into home care. You don't want to know, you don't want them to have rugs all over the place that they could slip and trip on unless they were stationary type, you know. You don't want to, you want to look at, do they have any type of fire things going, fire, you know, alarms and that carbon dioxide alarms and that type of thing like that. That's the type of things you want to look at. Footstools, electrical cords, you know, you want things to stand out. You want things to be either high or low enough for a person. You want to pay attention to the fact that if a person is sensory deprived or like lacking something like that, they may, you know, you doing things to help enhance them be able to use, do what they need to do. Know the difference between sensory deficit overload and deprivation. that's a very important thing. Sensory deprivation, person does not have enough stimuli. And then sensory overload, they just got too much. So sensory deprivation is when you don't have enough quantity or quality or stimuli. A person can be bored, restless. They can have increased anxiety. They can be emotionally labile, which means they 1 minute they crying, 1 minute they smiling. And then like if they got sensory deficits, which those type of things, or when they have low vision or blindness, or they usually come from some type of disability. And a person with sensory overload is just where it's just too much stimuli going on. And it just so, the brain just tends to have difficulty distinguishing the stimuli. So therefore they don't perceive their environment like it's making sense. It's just too much going on. So, know those. Just kind of know what it results in, how like a person may act as a result of these things. So let me see what else did. Okay, interventions. I'm trying to make sure I'm going back a little bit and be able to calculate pounds, kilograms, and liters. We're good with that. I know that y'all know how to do that. Wait a minute. Did I? I want y'all to know those 6 subscales in the Braden scale, that where you will be able to pick them out. And that's for the risk of pressure ulcers. So the Braden scale: sensory perception, moisture, activity, mobility, nutrition, and friction. Nutrition, friction, activity, mobility, moisture, sensory perception. Know those 6 things. And friction and sure goes together. Nutrition, mobility, activity, moisture, and sensory perception. Know that those areas are what is being assessed when you look at the Braden scale. Be able to say, these are the areas. If I was to throw in some other words, you would know that, oh no, they don't assess that when they use in the grading for the Braden scale, to assess, how prone a person is to get skill breakdown. Okay, so I think I had forgot that one. We'll go back. We talked about homeostasis and stuff. what type of things place people at risk for orthostatic hypotension is low fluid, because they'll pass out, decreased blood volume, dehydration, recent blood loss, as well as prolonged bed rest, anemia, or antihypertensive medicines place people at risk for orthostatic hypotension. So be able to pick that out. And okay, I think that, let me see, do I have another? I think that'll be it. If you have any questions, like over the weekend or during the time when you're going through this study guide and when you listen to me, but what I'm trying to tell you is everything, even though it may not seem like it, everything that I'm saying to you is truly, truly worth listening to, because I throw little clues and stuff in everything that I say. So just kind of listen to what I'm saying, see how much of the study guide you can put, fill in based on what I said. If you have any questions or have any problems with anything, like understanding anything, feel free to let me know. And good luck, you guys.
Bye.